Transient synovitis or toxic synovitis. Transient synovitis is a reactive arthritis and is one of the common causes of hip pain in young children. Regarding etiology, there is no definitive cause of transient synovitis known, although the following have been suggested. The first one is post-viral immunologic synovitis, because it tends to follow recent viral illness in around 70% of cases. The other possible risk factor is trauma. Patients with transient synovitis often have history of trauma, which might be a cause or predisposing factor. The other can be post-vaccine or drug-mediated reaction, and an allergic disposition have been cited as a possible causes. Although transient synovitis can occur in all age groups, it is most prevalent in children between 3 and 8 years of age, with a mean onset at age 6 years. Approximately 70% of all affected children have had a non-specific upper respiratory tract infection 7 to 10 or 7 to 14 days before symptom onset. Symptoms often develop acutely and usually consist of pain in the groin, anterior thigh or knee, which might be referred from the hip. Sometimes it might confuse with knee pain because of a referred pain from the hip. These children are usually able to bear weight on the affected limb and typically walk with an antalgic gait with the foot externally rotated. The hip is not held flexed, abducted, or laterally rotated unless a significant fusion is present. They are often febrile or have a low-grade fever less than 38 degrees Celsius. Regarding diagnosis, transient synovitis is a clinical diagnosis, but laboratory and radiographic tests can be useful to rule out other more serious conditions. In transient synovitis, infection labs such as ESR, C-reactive protein, and the WBC are relatively normal. But on occasion, a mild elevation in erythrocyte sedimentation rate is observed. AP and the frog leg lateral radiographs of the pelvis might be acquired and are all usually found to be normal. Ultrasonography of the hip is preferred to X-rays and often demonstrates small joint fusion. The most important condition to exclude before confirming a diagnosis of toxic synovitis is septic arthritis. Children with septic arthritis usually appear more systemically ill than those with transient synovitis. The pain associated with septic arthritis is more severe, and the children often refuse to walk or move their hip at all. High fever, refusal to walk, and elevation of ESR, C-reactive protein, WBC count all suggests a diagnosis of septic arthritis. If the clinical scenario is suspicious for septic arthritis, an ultrasound-guided aspiration of the hip joint should be performed to make the definitive diagnosis. The treatment of transient monoarticular synovitis of the hip is symptomatic, activity limitation, and the relief of weight bearing until the pain subsides. Anti-inflammatory agents and analgesics shorten the duration of pain. The preferred anti-analgesics and anti-inflammatory agents is non-steroidal anti-inflammatory drugs such as ibuprofen or naproxen. Advise bed rest for 7 to 10 days, allowing the patient to rest in a position of comfort. Advise the patient with transient synovitis not to bear weight on the affected limb. Advise the patient with transient synovitis to avoid full and restricted activity until the limb and the pain have resolved. When we see complications, sequelae include coxamania and mild degenerative change of the femoral neck. Coxamania is observed radiographically as an overgrowth of the femoral head and the broadening of the femoral neck. Coxamania leads to dysplasia of the acetabular roof and some laxation. Leg calviparous disease, it develops in 1 to 3% of individuals with transient synovitis. When we see the prognosis, patients with transient synovitis usually experience marked improvement within 24 to 48 hours. 2/3 to 3/4 of patients with transient synovitis have complete resolution within 2 weeks. The remainder might have less severe symptoms for several weeks. The recurrence risk is 4 to 70%. Most recurrences develop within 6 months.